Wonderful, Whānau, thank you. I'd like to welcome Dr. Helen Lockett to the stage from Work Counts to talk about the program they're doing. Thanks.
No, stay. This will be better. This will be better. No, stay. Stay. That's all right. It's all right. No, stay. It's great that you've stayed. Tēnā tātou katoa, no ingarangi o, ko Helen toko ingoa, kia ora tātou katoa. Whilst I do hail from England, I've been living, as you can see from there, on the beautiful Horomaka, the Banks Peninsula, for the last 10 years. If you're a Cantabrian, anyone? I emigrated between the September earthquake and the February one. That's how I can tell how long it was. That's how I measure how long I've been here in terms of which earthquake I came in between. I have a strategic advisory role for WISE Group, which is a non-government organisation working in the mental health and addiction space, and particularly with this work for the entity called Work Counts, which we're going to talk a little bit about. Many of you might say, last time I heard Helen, she was talking about Equally Well. Right? So I brought some leaflets, because I'm not going to talk about that, so they're here. I'll leave them out at lunchtime. But of course, I'm going to talk about employment and mental health, which is absolutely related to Equally Well and looking after our physical health as well. A couple of other hats I wear. I've done some work for the OECD, most recently on the Aotearoa New Zealand Mental Health and Work Report. I'm going to talk a bit about that today. And also, I sit on the Pegasus Population Health Advisory Board. And so have, over the last 5 or 6 years here, particularly increased my understanding of the primary care environment, particularly. And then the last thing, just to carry on introducing myself, these are my two mokopuna who live here in Wellington, so it's always a lovely treat to come up and see them. One is Jago and one is Ruan, and they don't call me grandma, right? Not in public, that's important. No, but they call me G-Ma, but the younger one can't quite say G-Ma and says Me-Ma, so he's going Me-Ma, and Jago's imitating him because he thinks it's highly amusing. And in fact, actually now Ruan can say G-Ma, he still calls me Me-Ma. But that's not what I'm here to talk about. But if you want to get me off the subject of employment and mental health, then just bring them up. So why is this important? And I do really thank you for coming and staying and thinking about this. And I'm thinking about what John said yesterday. He said, be brave, didn't he? And as I was sitting listening to him, I thought, why have you put an abstract in on employment and health? Employment, and I've worked in this area for over 25 years. So all my time in mental health and addiction services, I have looked at honouring employment aspirations. And yet, this is 20, and we still don't have a lot of change in this area. So I guess I'm so delighted that several of you are here and listening. And I think, well, even if one person was only here listening and they take away and change their practice as a result of this, then I would just be delighted. But hopefully many of you will, and I'll be around and also to take questions, because 20 minutes isn't a lot of time to cover this. And whilst colleagues yesterday afternoon on the panel, I was really pleased to hear employment and education coming into that kind of focus conversation. It hasn't been a big part of what we've been talking about. So health and employment are inextricably linked, aren't they? So our health affects our working life, and what work we do and what we do affects our health, especially when we're living with a long-term condition. Yet I don't think, I know we don't often make this link in the delivery of health services, and I'm going to talk about some of this link in relation to my own experience around mental health and addiction services, but you're all working across the board, and I know that you'll be able to apply it in the work that you're doing. So just take a moment and think about when you last saw your health practitioner and ask, when was the last time someone asked you what you do for a living? That wasn't the drop-down box that your job doesn't fit into. Right? So when was the last time someone talked to you about what you do for a living in any depth? You saw your GP, you saw your specialist. My experience is it doesn't happen. It doesn't happen on any detailed level. And I think that it could and it should. And there I am being brave, thinking, oh, you're thinking, oh, here's another thing to talk about. But actually, it's so important to our lives, isn't it? I have ulcerative colitis. I've had it since I was 19. Is that a long-term condition? Yeah, thank you. I didn't know if I was fit. So, you know, we never talk about how when it flares up. I never talk to my specialist, I never talk to my GP. Now, I am managing it well, but actually there's lots about my job that affects my ulcerative colitis, and there's lots about when I have a flare-up that affects my ability to travel and to work in new places. I would get very nervous about doing a presentation like this if I have a flare-up. Yes, so why are we not having some of those conversations? You have a massive role in this. The other thing I just wanted to say a little bit about, and I'll flag this because I will use the terms mental health and addiction issues more broadly when I talk about some of my work or our work in this field. And if you heard Caro and Rhonda talking yesterday, Caro Swanson was key to developing this resource, which is Real Language, Real Hope. And I really encourage you to go and download it from the Te Karanui website because it's about using language sensibly. And I heard someone say yesterday, her obesity, and I thought, oh, well, you know, it's hard, isn't it? You know, it's something. Someone is living with obesity. You know, it suddenly belongs to somebody, and that's really difficult. And if we say addict, and we say schizophrenic, and we say diabetic, it's hard. So I think you read that and think about language. I'm talking about people who, mainly when I talk, I'll be talking about people who are diagnosed with a mental illness or an addiction. But I will use the term mental health and addiction issue or lived experience for those things. I think it's much more strengths-based. I wouldn't want to be called an ulcerative colitis or something along those lines. I want to be called Helen, and I have a diagnosis of ulcerative colitis, and that's what I'm living with, and I have great experience in that area. So that was my plug for that resource because I think it's so important, and it can turn people off. If you deliver a presentation. And I was at a conference the other day, and it was entitled Treatment-Resistant Depression. I was like, oh, I don't know, it might be really interesting, but I've gone, you've lost me. So for most people, and I know it doesn't always feel like that in our jobs, but when we have a job, you know, most people work has a positive influence on our health and well-being, or we can make adjustments so that it's important to our health and well-being. And you know, I think many people know, long-term work absence and unemployment have a negative impact on our health and well-being. So many people who are living with long-term conditions, if you're not working, and if it's not a mental health or addiction issue, your chances of developing a mental health and addiction issue significantly increase the longer that you're off work for. And your suicide risk significantly increases. So actually, whilst we talk about the numbers of people who have a mental health issue going up in terms of claiming benefits, that's people who have put forward that they have a mental health issue as a result, and that's their reason for claiming. But actually, many people who are on benefits, many people who are not working, have mental health and addiction issues. So it's almost better to assume that rather than not. So we know that. The other thing is, the longer you're away from work, the harder it is to return to work. Yeah, so 4 weeks is a critical. So most people will return within 4 weeks. If someone's not returning after a period of 4 weeks, then we need to think about that. We need to think about offering some support for that. That's a crucial time. And if you think about your own work in terms of other areas of the health system, let's think about vocational rehabilitation in that same way. So if you pick up somebody while they're struggling at work, so if you pick up cancer early, you preventative care, we try and get that. We could try and get somebody in treatment within 4 weeks. We have targets around that. Vocational rehabilitation is exactly the same. And actually, the longer you've been out of work, the harder, less likely, and more costly it is to help you back into work. So why do we not take the same framework to think about how do we support people if they're struggling at work? How do we know if someone's struggling at work if we're not talking about it in healthcare settings? Because that's where people are. And the other thing I wanted to point out, and I think this is what's getting in our way, is the model of getting better first and then returning to work is unsuccessful and unhelpful. So the idea that I get better completely and all my symptoms go, and I no longer have ulcerative colitis, and then I go back to work, it's just outdated. In fact, it's actually really, it's more than outdated, it's unhelpful. And this problem is that we've designed our systems to deliver those services one after the other, and not together. And I do want to bring up this important point around long-term conditions, because most long-term conditions are not covered by ACC. And in ACC, whatever you think of ACC, whatever your experience of ACC, it does provide integrated health support, clinical treatment, and vocational rehabilitation, or employment, what I would call employment support. And if we're working in the health sector, we have to think about how we build an integrated system for people with long-term conditions alongside the Ministry of Social Development and Work and Income and the employment support providers that are contracted in this country. So we have to think about an equivalent system, otherwise it's just unfair. So how do we do that? What could we do? And the other thing I hear is that people don't want to work, right? David Kadar was just saying to me, I was just gone out, but people don't want to get well, and people don't want to work. We have these myths, don't we? So people don't want to work. If you ask a young person who experiences psychosis to put the following in order of importance, what would they order be? What do you think? Health? Employment? Housing? Relationships? Housing, yep. Housing. This is based on a study in Australia, but actually it's employment and education. Employment and education is crucial to young people with the first episode of psychosis. Housing, relationships, health. And often that's the exact opposite in which we prioritise, or at least we order services. Yeah. Actually, I'd really like health treatment to help me get back to uni. I'd like you to help me manage my voices while I'm at uni. Yeah. I'd like you to help me. And I was really good in the health service, and we talked about my levels of anxiety, and you discharged me. But then I started work, and I got more anxious. And now I need you. Now I'd like you. So what we talk about is the practice of what I would call work or education-focused healthcare. Yeah. So talking about work, thinking about work, offering clinical support in someone's working life, or helping them while they're at uni. So not out of situ. Is that making sense to people? So we think about what that type of clinical treatment should be. And I think we don't. We're geared up to think about symptom recovery rather than functional recovery. And if you look at this OECD report, you'll see that we've recommended as a policy change that return to work, or being at work, or staying at work in some form is a performance measure for the health system. Across the health system, how would that differ? How would your practice differ if it mattered? If and I'm not, we need levers and we need energy from the, across services. We don't want another type, but actually it would look very different, wouldn't it? And how different is it if and I've heard this in mental health services, if a psychiatrist says to somebody, I expect you to go back to work. I don't know, David, if you say that, and it's quite different than if actually, that I'm your work and income case manager, because there's lots of other things that are going on there, and you say, I expect you to go back to work. Sounds different, doesn't it? So in health, you have an amazing opportunity to have a very hopeful and positive conversation and getting yourself familiar with the evidence base and the support services that are available to you. So people want to work. And let's make it and. How do we deliver healthcare services that have an employment focus? So I'll talk about the statistics around mental health and employment. So just to give you a little bit of an idea of this, there is actually a bit of a declining unemployment rate, or employment rate, if you like. This is the employment labour force participation rate. So if you're living with a mental health and addiction issue that actually is being managed through primary care, that you may be going in and out of work, as a group, about a 60% employment participation rate, compared to the general population, which is about 75%. But if you're somebody in contact with specialist mental health and addiction services, your employment rate jumps right down to probably less than 10%. Yeah, and it'll be similar in terms of other health conditions. I also want to add, if you're Māori or Pacific, your employment rates are even lower, and you're living with a mental health and addiction issue. So again, in the OECD report, it's really clear that it's a significant disadvantage if you're Māori or Pacific in terms of your likelihood of participating in employment or education. And then you can put that in risk if you're living with a mild to moderate mental health or addiction issue that's being treated in primary care. You're twice as likely to be unemployed. You're 4 times more likely to be unemployed if you're in contact with specialist mental health and addiction services. So lots of figures for you, but it's a sliding scale. What does that mean in terms of what we offer? Because it's not about workability, actually. It's about the support services and the systems that we create around people. One of the things we've said very much in the disability movement is actually anyone can work if they get the right support around them. And most people really want to do some sort of work. So I often describe employment support as low intensity and high intensity. And I'll explain about what I mean. So anyone here from Work and Income? Ministry of Social Development? I didn't think so. It's a long-term conditions conference. But we could be, couldn't we? We could be extending our networks out so that we all listen to one another. I always learn lots when I'm at a non-mental health and addictions conference. So low intensity is our public employment services. Does anyone know the lowest case manager at Work and Income? What's the lowest caseload of people that they would see at any one time? Oh, thanks. Well, that's really scary, that. 80. Yeah. Now, that's okay for lots of people, but if you face multiple challenges to getting back to work, that's not going to work for you, which is why it doesn't work for most people. So what we're talking about is offering a high-intensity, a higher personalised employment support service, and we need to integrate those in health services. And I'll speed through this, but basically there is an evidence-based practice that helps people with mental health and addiction issues get back to work. We implement that in New Zealand. And we just need to make these more readily available because you in health services need to think about how to have the work conversation and where to refer to. But there's no point in you not having a good quality employment support service to refer to. So this is an evaluation of an employment support service integrated into a specialist mental health and addiction team. And this is a comment of a manager in the team after they had an integrated employment advisor in their mental health team. An interesting thing about Gatekeepers yesterday. We had to examine the thought that we were becoming barriers to people starting work rather than helpful. Because we were determining when we felt they were ready to go to work as if that was something we had ownership of. Who came round and assessed me last night to see if I could do this presentation? We don't, do we? But we do in mental health and addiction services often. So why is it hard to ask about work? And I think it is hard because we often don't have the quality employment services. And I guess I'm saying to you, you can have quality employment support services and you can ask them and expect them. And if you can advocate in your roles for those. But also it can be hard because you're concerned about somebody relapsing. You're concerned about how to support somebody if they have not worked for a long time. So there are lots. I can see why it would be challenging. But actually, it could be an amazing conversation to open up. And whilst I think I was saying earlier, I think this is a brilliant toolkit, as far as I could tell in it, there's nothing that says, what about your work aspirations? Because we don't ask about it in health. But we could do. So it is hard, but try it. Think about asking people about work. But we do want to make sure someone is supported well when they go back to work. So in Northland, they've been trialling within Te Araoranga, the methamphetamine harm reduction pilot. They've been trialling having employment specialists integrated into the addiction and mental health team up there. And I just want to give you a flavour, because if we can support this a group of people who face multiple challenges back to work, then we can support many, many people with a long-term condition back to work. So just to say a little bit about the demographics who are using that service, so that just gives you a bit of a feel for people. So 40% of people had a primary diagnosis of addiction, or if they didn't, they had a secondary diagnosis of addiction. Yeah, most people, high numbers of people had been out of work for more than 12 months. And that goes back to what I was saying. By that stage, you need personalised intensive employment support services to get people back. But the clinical team now have an employment specialist co-located in them, and they work as an integrated member of that team. So one of the clinicians, when they started the pilot, said, we all thought, what a great idea, but there aren't any jobs here, right? So it's not going to work here. And the people you're talking about are way too unwell, and there's too many things, happening for people. And I know that the referrals come in and they go, well, good luck with that one. That person's not work ready. And a colleague of mine replies, well, I'm not sure that we were ready, actually. Let's stop putting it on the person. Yeah. So actually, we weren't providing the support services. And what happens when we don't provide the support service and someone who's facing multiple challenges to get back to work, has to go and work with the case manager. No disrespect to the case manager, they're doing their best at their job, but they've got 80 people. Yeah, and so nobody feels good, do they? So we've got to provide the better services for people. So that's just at 12 months. At 12 months. So 2/3 of people, nearly 2/3, had already got a vocational training or paid employment. Get me at lunchtime, I'll tell you about how a whole group of people are now extras for Lord of the Rings as well. So, because, amazing stories. So you can, but let's provide employment support alongside healthcare, because now the treatment that people are getting is in line with what they want to do. Let's think. Actually, I'd quite like to work with David. Poor David's going to get caught out, but David, I'm a psychiatrist, and David, I'm drugged up. I'm drugged up. I'm so tired in the mornings. I can't do my job. But Helen's going to help me get this job, and so can we look at reducing my medication? Can I work with a bit? Oh, okay, you're getting a job. Okay, great. And I know Helen because she works in our team. Let's help you. Let's work together. Yeah, and that's for people who've been out of work for some time. Just before I finish, just a couple of things. And if people want this work, Becky's been working on this as a master's. But just amazing stories, amazing looking at what it really means for people, that we reach for the sky for people. And again, I'll just give you a quote from the clinician there. And this is lovely. You can sell meth. Well, you can sell something. You must have some strengths there. Honestly, this is this, and also we go with employers and we say, you'll know this person. Yeah. And they're wanting to turn their life around, and we're supporting that person. And the health team and the employment services are supporting that person together with their family whānau and the person. So, in summary, you're pleased, aren't you? Health services have an important collaborative role, and honouring and supporting employment aspirations. I really hope that from the 20 minutes I've spoken to you, you can think about that. We've got to increase access to these personalised, high-intensity employment services, especially for people with long-term conditions. We've got to make an equivalent system across health and MSD to ACC. We have to. It's not fair currently. It's not fair at all. And our government has said we have an equivalent system, and I don't believe we have. So let's make it. So employment support and health treatment should be integrated so that we can have that wraparound support. You can advocate. You can give people my name if you want to meet with me. But advocate, be champions. Think about how important this is in your work. Try it out, ask. Find the employment support services. Bring them into your clinical services and work with them. You can do so much on the ground. Thank you.